Thank you for your patience. Okay, welcome to the November Talk with the Doc with Dr. Licklider. Thank you as always.
Thank you, Casey. Well, I'm going to mute everybody just to keep it simple. So, Casey, if you want to talk, you have to unmute yourself. Welcome back, everybody. As usual, same scheme as every other time we've played this game. For those of you who have been here before, welcome back. For those of you who haven't, welcome to the party. I'm Dr. Licklider. I'm a movement disorder specialist sitting here in my office at Allegheny General Hospital. I'm part of Allegheny Health Network, and I run the movement disorder clinic here and the Parkinson's clinic here. And this is basically a question and answer session. So send in your questions. There's a chat box down here at the bottom. You can type in your questions there, and I will answer them as they come in. I always start with the ones that we got via email first. So once I get through all those, then I'll go to the chat box and we'll go from there. A couple things I like to throw up is this is kind of a general forum for questions. So, specific questions about your treatment strategy or your plan or what we should do next for you are probably best between you and your doctor. Maybe not a great place to do it here. And everything you're going to hear is going to be my opinion. I got a lot of opinions, but everything you hear is my opinion. So you might go to a different neurologist or a different movement disorder specialist or a different doctor, and they may have a different opinion. But everything is my opinion. I like to think my opinion is mostly as scientific as I come or as I can be. But if it isn't, then I'll try to tell you I'm making stuff up, or I'll throw up some quotation marks and let you know that I'm making stuff up. With that being said, I'll get started with the questions and we'll go from there. So the first one I got was actually about something going on in Europe. So it was, what are my thoughts on the recently approved ABBV 951 for Parkinson's disease in England? And what this is they took levodopa and they made it more stable, and they put it into a pump that can directly get pumped into you via the skin, so a subcutaneous. So we have a pump that's available in this country called Duopa, which is a levodopa gel formulation that can be directly pumped into your small intestines, but this requires a tube put in. Interestingly enough, about the one they're working on in Europe is it really is just a subcutaneous thing, so there's no tube or things like that. Not approved here. And so again, I'm just like everybody else. I'm watching and waiting, right? The FDA in this country is actually really hard to get things that are approved in other countries approved here. Even things that have been used in Europe for 5-10 years. Sometimes it's hard to get those approved through our own government agencies. A lot of times they do make them do extra studies or another safety study or an efficacy study. And so I'm not sure where it's at in terms of what the FDA is requiring them to do. But I'm interested because anything that helps smooth out ups and downs, which is the idea of this type of a pump, allows people to take less pills, which would be nice, is definitely going to be a useful tool in the armamentarium. I don't think it'd be right for everybody. I don't think this will replace pills as we know it. But it's always nice to have other ways to get medicine into people and other tools at our disposal. And so I'm as interested as you guys, watching and waiting for different types of approval to come through. And once we're able to actually get our hands on it in this country, then I'll have more to come about that. But again, just keep in mind that things that happen in Europe don't always get here quickly. Let's just put it that way. This is more of a specific question, but I'll see if I can extrapolate it to everybody else. So my mother takes 2 Cinemet 3 times a day and 2 extended release at bedtime. She's not able to walk anymore. Would increasing her medicine help? She used to take the Comtan tube, but quit taking it. She's never really had downtime or kind of these fluctuations that people hear about. She used to be able to walk with a walker slowly, but now she's really using her scooter. She's slow. She has a lot more stiffness, so on and so forth. And so what you're hearing is a couple things, and these are common themes that I get all the time. So first is, not everybody feels the medicines work. So I get asked a lot of times about, hey, I hear a lot of people talk about a medicine kick in or wear off or on and off times. What does that mean? I don't feel any of that. I don't feel the medicine work. I don't feel it wear off. Is it a me problem? And the answer is no. Not everybody feels the medicines work, but a lot of people do. And when they feel it work, they feel better. So The medicine kicks in, they're less stiff, they're less shaky, they're less slow, they move a little bit better, and then it wears off and they're back to being stiff, slow, shaky, so on and so forth. And that's what we typically are referring to in terms of on and off. And you'll hear us talk about that in research and things like that. And you also, and that's usually kind of what we talk about when we're talking about fluctuations, which again, not everybody has. Now, you might not have those for a couple of reasons. So one is you may be doing great. You're not having the wearing off or the ups and downs, so-called the honeymoon period, where everything works great and you don't, really feel like you need the medicines. They work. You don't have to worry about them kicking in and wearing off, and that's a good thing. But there are people who don't respond very well to the medicines too, and I wonder if that's the situation that we're dealing with. Now, just because you're not responding to the medication doesn't mean that there's a better medication out there. And so I get that question a lot too. And so in this case, again, the best way to find out if the medicine's helping might actually be to taper her off of it and see what happens. I'll do that not infrequently when I have somebody who comes in and we're not really sure if the medicine's giving them any benefit. We're not really sure if the medicine's helping. Even Cinemet, we'll taper it off and see what happens. If you're worse coming off of it than it was helping, we can always put it back on and increase it or layer in different things. And so that might be something that you think about too. The hard part is as you stop walking or as you stop moving and you're not doing as much, things get worse too. And so, the problem in that scenario that I read is that everything's getting worse. The medicines don't seem to be as effective as we would like, and now we're getting less exercise and less movement. We have to figure out what the medicines are doing. We probably have to figure out other medicines or more medicines to do our best. We might need some therapy, but we got to figure out how to get her moving more, doing better. And that's really what I would do or what I would aim for if it were me. If it is me, that's what I'm going to do. If it's not me, that's probably what I would recommend. But again, that's a tough one. When you don't feel the medicines are working, then we're never really sure are they helping. And then you have to do more work to try to figure that out. And if they're not helping, then we're a little bit limited in terms of, kind of the successful medications I think we're going to have. I feel a lot better about the other medicines being effective if carbidopa levodopa is helping. And so a lot of question marks there. I'm not sure I have a great answer, but it does sound like there's a lot of work that needs to be done. And the medicines probably need to be adjusted. We may need some therapy, but we definitely have to figure out a way to get her up moving more. The short answer to the follow-up questions, which is there anything else that she could be doing, or why take the medicines if they're not that effective? Again, working on exercise and getting up and being active, but also looking into, is this a Parkinson's plus condition, or is there something else going on that could explain it? And the second part of that question is exactly something I ask all the time, which is, I certainly don't want you taking a medicine if it's not helping. And so this is exactly the reason for doing a lot of the tests that I do, where I'll take somebody off of their medicine to find out if they're working. If you do get worse coming off the medicine, then they are indeed working and you need to put them back on or more. But if you stop the medicines and they're not really helping, then they really weren't doing a whole lot to begin with. And I don't think anybody's going to want you to keep taking a medicine that's not doing anything. I don't think there's any doctors out there that just want you to take medicine for fun. And so if you're my patient, or if you're, somebody that I see, if we take you off of medicine, you're the same, then it wasn't doing anything. And we need to think of a completely new strategy. But I agree with the idea. Why would you take a medicine if they're not doing her any good? So again, a lot to work on there, and hopefully that answered the question. I actually had to look this one up because I was like counting on my fingers. So the question was, can you please discuss the differences between the 6 main type of Parkinson's disease medicines? And then I had to go back and think, well, what the heck are the 6 main type of Parkinson's disease medicines? And I actually had to Google that question because I only came up with 5 and I wasn't sure what the 6th one was, but they labeled amantadine as its own class of medicine. So I thought that was cheating. Anyway, let me give you a brief tutorial here about the medicines. All of the medicines that we use in Parkinson's disease are aimed at dopamine. Loss of dopamine is thought to be one of the underlying main hallmarks of Parkinson's disease. Carbidopa levodopa is the gold standard medicine we have. So there's multiple varieties of carbidopa levodopa: Cinemet CR, Parcopa, Rytary, Imbresia, you name. There's infinity types of carbidopa levodopa. Levodopa is the step before dopamine. You can't see my brain behind me or my pathways behind me, but on my board I have this drawn out. We learned a long time ago that you can't just take dopamine. I can't feed you dopamine. It doesn't get from the stomach to the brain. It doesn't work. But if you take levodopa, which is the step before dopamine in the conversion, it gets from the stomach to the brain. It gets converted into dopamine. And this is the best and closest thing we can do to replacing dopamine in the brain. So all the versions of carbidopa, levodopa are aimed at increasing dopamine in the brain. I'll come back to what carbidopa and what levodopa do later because I'm pretty sure there was a question on that too. The next most common class of medicine we use are the dopamine agonists. So this is Mirapex or pramipexole, Requip or ropinirole, Nupro, rotigotine, Apokyn, apomorphone. These are dopamine agonists. And so what these medicines do is they activate dopamine receptors. It's not dopamine itself, but they activate the receptors to get the same response downstream as having natural dopamine. And so they work more or less as synthetic dopamine is the way that I view them or picture them. So that's two. The next two classes of medicine are aimed at preventing the breakdown of dopamine. So dopamine is broken down by two enzymes in the brain, monoamine oxidase. And so the next class of medicine are the monoamine oxidase inhibitors. This is Azilect and selegiline. These prevent the breakdown by preventing monoamine oxidase from converting dopamine into something else. Catecholomethyltransferase is COMT. So the COMT inhibitors or COMT inhibitors, which are entacapone or Comtan or Ongentys, also prevent that enzyme from breaking down dopamine. And so those are two more classes of medicine to prevent the breakdown of dopamine. And if you prevent the breakdown of dopamine, you keep dopamine around longer. That's why they help people do better. The fifth class I could come up with was the anticholinergic. So this is trihexyphenidyl and benztropine, Artin and cogentin. And these are actually predate Sinemet in terms of being used for Parkinson's disease. And they actually work more on acetylcholine than they do on dopamine. Acetylcholine is the chemical that actually makes your muscles contract, and that's how these medicines tend to work. They tend to work for rigidity, they tend to work for tremors, but they come with a hefty side effect profile, and this is why I don't use them as much as the other classes of medicines that we talked about, but they exist. And then the other kind of non-classed medicines would be things like amantadine, which I use all the time, which actually works on a couple different chemicals, Norians, which works on something different that I'm blanking on right now would come to me in like 35 seconds. Chico will be mad at me, but I'll come up with adenosine. That's what it works on. And so there are these other scattered types of medicines that don't fit into any of those categories, but that's the general idea and classifications of the medicines that we use. There are other medicines that we use that I didn't mention, but those are the general classifications. And the idea is that all of them are really aimed at some way, shape, or form dopamine or other chemicals that help you move a little bit better. Hope that's what you were looking for, but that was the best I could come up with. What do you do about chronic constipation? We've tried many things and been to the gastroenterologist, doctor. Any thoughts? So constipation is one of the main non-motor symptoms of Parkinson's disease. And it's not just constipation, it's the entire gastrointestinal system, top to bottom, is affected. Swallowing, chewing, swallowing, stomach emptying, intestinal motility, large intestinal motility, or constipation. These are all major issues that come to my office, and they're all really hard to fix. If you've tried a lot of things and you've been to the gastroenterologist, I'm probably not going to be much more helpful to you than what they've already done. Generally, a lot of my patients end up on some sort of bowel regimen. So generally they start off mild and they work their way up to more progressive or more severe things. So starting with a stool softener, maybe you need a stool softener every day, and then you add in a laxative as needed. Maybe you need a stool softener and a laxative every day. If you get to that point and you're still having trouble, then I start adding in things like Linzess. Linzess is a medicine that I use only because I stole it from the GI guys that seems to work for constipation. I'm by no means the Linzess expert. If that doesn't work, I usually get you to the gastroenterologist. You know, some people do enemas. There's a whole variety of other things you can do, but it's a really hard problem to work on. It's a really frustrating problem to work on too, because, you know, bowel movements and going to the bathroom, urinary issues, bowel issues, these really impact day-to-day life, and they're really frustrating. I'm not sure I have a better suggestion for those things compared to what I already said. Really, if I got to that point, I would be referring to a gastroenterologist to see if there's something they could do, something they could help. I don't think I've ever met a GI specialist who really had a lot of knowledge or interest in Parkinson's disease. That would be nice, but I don't know any. And so at the end of the day, we work with the people we can find in whatever system you're in, and we see if they have any other suggestions. But, kind of working through that progression is how I tackle that problem in my office. And oftentimes it's successful. But believe me, I've had plenty of patients who do all of those things who still struggle with it. And then we really aren't sure what to do or how else to tackle that problem. And again, I'm by no means the best gastroenterologist in the world. This is why I refer a lot of patients to other people. And it really is finding somebody you can try to work with. All right. Can taking a short-term course of steroids affect Parkinson's disease tremors? If so, would it be permanent or temporary? It probably could. So steroids can definitely make people shake more. They tend to amp you up. They tend to keep you up. They tend to impact sleep. And so I could imagine, and I don't know if this has ever been written about, but I can imagine steroids would amplify tremor. I would think it would be on the order of temporary, meaning when you're taking the steroids, it may flare up your tremors, but after you taper off or as that course comes to an end, that should calm down. But I'm not entirely sure because other things that you think should be temporary aren't always. Things that impact tremors, sometimes even though we think they're temporary, can actually lead to progression of symptoms. And so even though at first glance I would think that that would be more temporary, I can't say that for certain. And, you wouldn't really know until you tried it. My husband has started to have migraines. Could the Parkinson's disease or the Cinemet be the cause? One of the it could be. I've had some. I don't know that it's listed as a side effect of Cinemet, but I've definitely had enough people come in and tell me that they've had headaches after taking it that I have to assume that it can. Now, the other hard part is migraines are pretty common too. I take care of a lot of patients that have both, even though they're not necessarily related. Now, it would seem awfully coincidental that you've never had a migraine before in your life, and then all of a sudden you have Parkinson's disease, we put you on medicine, and now you have migraines. I mean, I would guess that those two things are related, but I'm not entirely sure. I don't know that I would do anything different per se, although you could think of maybe changing the form of carbidopa, levodopa as it comes in a bunch of different varieties or trying other medicines to see if you can get them doing better. And if that helps from a headache standpoint, or you may just end up treating like migraines too, which is not uncommon. And so I would answer that question with saying it could very well be a side effect of the medicine, probably more so than the disease, but you end up having to treat them both anyway. Is there a benefit to taking levodopa on an empty stomach to give the small intestine more ability to absorb, or is the carbidopa added to assist this? See, I knew there was a question about carbidopa and levodopa. So yes, levodopa works best on an empty stomach. Mainly because large amino acids, aka proteins, can interfere with the absorption of levodopa. And this part doesn't have anything to do with the carbidopa as far as I know. This is really a carrier protein that carries the levodopa from your small intestines to your bloodstream to your brain. And that same carrier protein also carries large amino acids. And so it's really just competition for this carrier protein. The purpose of the carbidopa is to prevent the breakdown or the conversion of levodopa to dopamine in your stomach. Because again, if you get dopamine in your stomach, it's not getting to your brain. And so you don't want that conversion to happen in the stomach or in the peripheral system. You want the levodopa to get to the brain before it gets converted to dopamine. Otherwise, it doesn't work. That is the purpose of the carbidopa. The carbidopa prevents that conversion from happening in your stomach or in your peripheral system and allows more levodopa to get to your brain. But it's the carrier protein that does that is blocked or really competed for by proteins and large amino acids. And that's why if you eat when you take your levodopa, it may be less effective. It works best on an empty stomach. Now, there are patients who take it with food and don't notice any difference. This is not everybody. I have plenty of patients that take their pills with food. In fact, taking it with food tends to help with the upset stomach or nausea, which is the most common side effect to it. And their pills still work, but not everybody is like that. I also have plenty of patients who, if they take it with food, it doesn't work as well, or it doesn't work at all. And so that's why. It's because of the absorption or the carrier protein being taken up by the proteins that block the absorption of carbidopa of the levodopa. So yes, the short answer to your question is if you take it on an empty stomach, it should be absorbed better and work better. My tremors seem to be well managed on carbidopa levodopa, but I'm having more issues with walking, mostly getting started and freezing. Other than exercise, which you knew was going to be my favorite answer, which I do daily, is there something else that I should ask my doctor about? Yep, pretty much. So the problem with walking in balance is it's a real and freezing of gait and hesitation and festination and call it a whole bunch of different things. These are really hard problems to fix with medicine. And even though carbidopa levodopa is the best drug I have, it's the gold standard medicine for Parkinson's disease. It's been around forever and it's still better than all the other ones. It also is not great for walking in balance. There's a lot of theories about this. My personal theory is that when you start talking about the cerebellum, which is what controls coordinated movement and balance, or the brainstem pathways, which we think are intimately involved in balance, they're not driven by dopamine. They're driven by acetylcholine. I think that's part of the issue. That's not proven by any means, but I think there's been enough written about that it makes a lot of sense. And this is exactly what I see in day-to-day life. Carbidopa levodopa works great for tremors and stiffness and slowness of movement, but when it comes to walking in balance and freezing of gait, I mean, it helps, but not a lot. And so the short answer is exercise is the best medicine. I send a lot of people to physical therapy to work on cueing, which helps you get unstuck or trying to prevent getting stuck, and work on really focusing, concentration, and cognitive ways to try to help prevent that. And then the other answer is I use other medicines. So this is an area where I would use amantadine, or I would use a different medicine to supplement with the carbidopa levodopa to try to help with walking in balance. Now, again, the other medicines aren't great for walking in balance either, but sometimes it does help to layer in multiple different medicines to see if we can get better results. And so if you're my patient and you give me a call and tell me that's what's going on, you could argue we should just increase the levodopa, which I might try, or we could layer in another medicine, or outside of exercise, it's getting you to physical therapy to really work specifically on walking, balance, and freezing of gait, as that's probably the thing proven the most and probably has the best literature and evidence behind it to work on that type of a problem. All right. One last question, I think, here. Let's see. Can you please discuss which symptoms of Parkinson's disease are helped by medications and which symptoms are not? For those symptoms that don't respond to medications, could you offer some insight as to why? That's an interesting question. So the medicines, as well as surgery, or basically any intervention that we have, work the best for tremors and stiffness and slowness of movement or bradykinesia. They work the least for walking in balance, speech, cognition. And I think the short answer to your question is it's because I think those things are more complex. They are not directly driven by pure dopamine pathways, meaning I think acetylcholine or epinephrine or norepinephrine or these other brain, dopamine is not the only chemical you have in your brain. I think the other chemicals or neurotransmitters in your brain are more intimately involved in things like balance, cognition, speech. And I think that's why they don't respond as well to the medicines. They still respond some statistically, but in my day-to-day practice, you're absolutely right. These are symptoms that are hard to work on, don't respond as well to the medicines. And I think if I had to figure out why that is, I think it's because of these other pathways, these other chemicals that are involved, these non-dopamine related pathways that we're not necessarily targeting with the medicines. Now, you might say, well, why don't you target those things with medicines? Well, because the brain is complicated and complex, and I don't understand it very well. And I can say that because nobody really understands it that well. You know, the brain is pretty complicated. We haven't figured it all out yet. But this is why I'll use medicines aimed at acetylcholine or norepinephrine. You know, I'll use rivastigmine, which is dementia medicine, or I'll use methylphenidate, which is an ADD drug, to try to help with those problems. You will see me use chemicals that work on other medicines that work on other chemicals to try to solve some of those difficult problems for just that reason. Now, I can't say they're tremendously successful either, because again, these are hard problems to fix. But these are all things that we think about or that we try when we're trying to help people quality of life or do better. And so I think that's the answer, is because they don't respond to the dopamine medicines because maybe they're not driven by medicine or dopamine, and we need to think of other things. And there's a lot of research into these things too. People are always looking at other medicines or different classes of medicines to see if they work. And this is also kind of the same idea for why you'll see studies on dementia medicine, or studies on a cholesterol medicine, or studies on these other medicines that you don't think maybe seemingly are related, but maybe they tackle a problem on a different level. All right. I think that was all the ones I had in the email. Let me scroll back up here and see what I got going on here. Does Parkinson's affect memory and cognition? Yeah, it sure does. So statistically, 50% of people with Parkinson's disease are going to end up with a memory problem. Now, that doesn't tell you the severity or anything like that, but at the end of the day, a lot of times people have memory problems. Now, the hard part about that is there's a whole bunch of different levels and varieties of memory problems, right? It could be anything from mild cognitive impairment that people get with the typical aging process, all the way to full-blown dementia and Alzheimer's disease. So interestingly enough, if you actually do pathology specimens in Alzheimer's disease, there's a lot of Parkinson's pathology, and vice versa. If you take a patient with Parkinson's disease who has a lot of cognitive decline and you slice open their brain after death, you see a lot of Alzheimer's disease pathology too. And so even though we talk about a lot of these things as individual and distinct disease processes, there is a whole ton of overlap that we don't talk about nearly enough. It's actually pretty uncommon to do a specimen study or an autopsy study on a patient and only see one type of pathology. That is actually very unusual. There's varying degrees of these things, but it's not too surprising to see a lot of overlap. And the hard part is we're not really that good at predicting who's going to do well, who's going to have just some mild memory problems, and who's going to have full-blown big problems. We're also not very good at memory problems, in case you weren't aware of that. It's not one of those things we have great treatments for or great medicines for. There are some, and I use them all the time in a lot of my Parkinson's disease patients. But at the end of the day, the results are iffy. And so the short answer to your question is yes, although the longer answer is paying attention for it, asking about it, talking about it, trying to figure out different things you can do, because there are some medicines. Speech therapy doubles as cognition or cognitive therapy, and exercise and being active tend to help. So there are some things we can do. So it is worth bringing up. It is worth talking about. It is worth thinking about, to at least label it, talk about it, discuss it, and figure out if there's anything that can be done about it. A virtual Parkinson's summit on November 14th to the 20th. We need as much information out there as we can get. Great idea. Interesting. I have atrial fibrillation and the doctor wants me to take blood thinners. And this is going to be true for just about everybody on this call. If you have atrial fibrillation, they're going to want you on blood thinners because atrial fibrillation puts you at a higher risk of stroke. Atrial fibrillation is when the top part of your heart does not beat and contract like it should. You kind of get one of these things, and that can allow blood clots to fill into these areas. Those blood clots can then go to the brain. That's a movement disorder specialist of cardiac and stroke neurology. I'm not the expert there. I don't know that blood thinners necessarily affect your balance, but if you already have balance problems, it definitely makes it more dangerous. Falling is the most dangerous problem to begin with. Falling is the number one reason that my patients end up in the hospital. You certainly don't want to fall and hit your head. You certainly don't want to fall and break things. Christine, I feel like more people should have their dogs in the camera, or dogs or pets in the camera. I feel like that makes my job a lot easier. Anyway, I digress. Falling is your most dangerous problem anyway. And if you're on blood thinners, that's going to make it even more dangerous, because if anybody who has been in here has been on blood thinners, as soon as you bump your arm or as soon as you even look at something, you have a bruise. The bleeding on blood thinners is so much more than just somebody on aspirin or even aspirin and Plavix, that falling becomes much more dangerous. So I don't know that blood thinners necessarily impact balance. They might. I'm not entirely sure of that literature. But if you're somebody with Parkinson's disease and you already have a balance problem, we have to be all the more careful, because falls are so much more dangerous on blood thinners compared to off blood thinners. Now, that doesn't mean you don't take your blood thinners, because at the end of the day, if the risk of you having a stroke is there, is it really worth having a stroke because we're worried that you might potentially fall and bleed? Again, this is where medicine is an art, right? Weighing out risks and benefits. If you're somebody who falls every day, I'm not keen on you taking a blood thinner. But if you're somebody who's never had a fall and your balance is okay, and the blood thinners are necessary, then it's worth the risk. And so this is where we're always trying to weigh out risk and benefits. What's the best answer? What's the most safe idea or choice? What's the least dangerous choice? And go with that. And so again, if your heart doctor or your primary care doctor think you need to be on blood thinners and you have a reasonable expectation of balance, it's probably worth it. But it just means you have to be all the more careful and work on balance, because falling is all the more dangerous in that situation. Donna, I'm going to have to look that one up. I'm not sure what risvodetinib is, but I'll look it up. I'll talk about it next time. I'll write that one down.
It's a trial based on people with Parkinson's that have been diagnosed with Parkinson's, but that are not on Sinemet or any medicines.
Oh, okay.
And it's based on another biology in the brain. It's called cellular Abelson tyrosine kinase, C-I. And they're trying to, if you have an overabundance of that, you develop the misfolded alpha-synuclein. So it's trying to inhibit that, and then your brain is able to get rid of that naturally, they said, with this drug. So it's a way to slow the progression and maybe even reverse it. And apparently they had a phase 1 trial. So this looked really interesting to me, but it doesn't help a lot of us that are on medicines. But if this goes true, then it may be able to help people on medicine.
Well, that's exactly what I was going to say. And so the problem is phase 1, just make sure it's safe, make sure it's not going to kill you. Phase 2 is when you start to see, is it worth trying? And then phase 3 is where the money's at. And so at the end of the day, again, you guys all know this just as well as I do. How many times do we get burned by phase 1 and 2 trials that look great? Phase 3 fizzles out. And so while I will look into this, because again, anything that decreases alpha-synuclein or allows us to naturally get rid of it, because we do think there is something with the buildup of abnormally folded or misfolded alpha-synuclein that leads to some of the pathology. In fact, alpha-synuclein is a huge target in a lot of research that's going on right now. And so if there is a way to, especially if you can target the misfolded version of it and get rid of it, it does have a lot of interest. I mean, that seems like a reasonable study or a reasonable thing to try. I am definitely, I'll believe it when I see it kind of person. So I don't get too excited about this stuff until I see it in people and I see it working. But I'll look at it and I'll let you know what I think next time.
Okay, thanks.
If only we lived in Chicago. So Rush has everything. So Rush is a health system in Chicago, or hospital in Chicago, and it's top class. And so I'm sure they have a gastroenterologist who specializes in Parkinson's disease. But as far as I know, I have not seen somebody in Pittsburgh, either in Allegheny Health Network or over at UPMC, that has any specialization or really any interest in Parkinson's disease. Back when the Duopa people, it was AbbVie at the time. I don't know if it still is, but back when Duopa was kind of up and running and they were trying to get me to use it more, I had one of our gastroenterologists here who I really like, and I kind of had her on board with putting in the tubes for me and things that I was interested in, if we needed it. But it's been a while since we did that. I don't think she ever really had a lot of interest in Parkinson's disease. It was just she was helping me because I needed somebody to put in a tube. And so as far as I know, we don't have anybody in Pittsburgh who specializes in Parkinson's disease from a gastroenterology standpoint. Boy, would it be really nice, because I could basically fill their entire clinic with patients. But again, hey, if anybody has any suggestions or find one, please let me know. I'll send them a whole bunch of patients. That's an interesting question. So please address the side effect of dyskinesia on Comtan. Incidence, how fast it can begin after starting Comtan. Does the dyskinesia completely resolve after stopping Comtan? So dyskinesia is a side effect of all the drugs. So dyskinesia means abnormal movements, so kind of squirmy movements, can't sit still, can't stand still, looks irritable, really just extra movements. And this is a side effect of all of the medicines that I use for all the dopamine medicines that I use for Parkinson's disease. And we think it comes back to that After so long of being on medicines, you start getting receptor changes. They get hypersensitive, then they don't respond correctly. And that's what leads to the dyskinesias. Comtan can do it too. So Comtan is entacapone. This is a COMT inhibitor, so it prevents the breakdown of dopamine. And we add Comtan to carbidopa levodopa to see if we can extend the dose, make it last a little bit longer, maybe up to a third. Adding Comtan can definitely induce or increase dyskinesias. But even if you're just taking Cinemet, it can cause dyskinesias. It can be as quick as right away. As soon as you take your first dose of Comtan, it can hit you. It could be maybe it takes you being on it for a while before you start to notice it. Theoretically, taking away the medicine that's inducing the dyskinesias could make it go away. And so if Comtan was added and you start having squirmy movements or dyskinesias, theoretically taking it away could take that dyskinesia away, although you wouldn't know unless you tried it. And I'm assuming the Comtan was added for a reason, so you're going to be back to where you were square one. The first and easiest way to try to work on dyskinesia is by cutting down the medicine. And again, this doesn't just apply to Comtan. It applies to Cinemet and Mirapex and Requip and Nupro and Comtan and Azilect and Slit and you name it. But if you can't, so let's say you need the medicine, because I have a lot of patients where they need their medicines to move, but you put them on medicines and they have these kind of side effects, then that's where amantadine is sometimes useful. So Gocovri is an extended release of amantadine that was actually approved for dyskinesias, and I'll use that too, but even sometimes just regular amantadine can help calm down dyskinesias. And so that's the other way to try to help. But the short answer to your question is it can start right away. And theoretically, it could or should go away if you stop the Comtan, if that's really what triggered it, but you wouldn't know until you tried it. You take carbidopa with Synthroid on an empty stomach. So I am not an endocrinologist by any means, and all that I'm ever told about Synthroid is it has to be taken by itself. I don't really know why. I assume it just interacts with everything, either it's less effective or why. I never really looked up why. I don't prescribe Synthroid, although I have a ton of people who take it. But everything that I've ever heard or know about Synthroid is that you have to take it by itself. Can you take it with carbidopa, levodopa? I don't know. But my understanding of Synthroid is you take it by itself on an empty stomach, and then you wait and take all your other pills. So I don't know that I would necessarily mix the two, but not because of the carbidopa, levodopa. I don't think that would impact the Cinemet. I would worry about the impact on the Synthroid. If your endocrinologist says you can take them together, take them together. But that's up to them. Oh, that's such a good question. Is there a way to tell when the condition is brain/judgment related versus just being stubborn in making decisions that aren't rational or best for the patient? That is a great question. Not really. I mean, realistically, outwardly, it looks the same. I just had this conversation with my very last patient of the day today where I was hearing a lot of, well, he doesn't listen, or he does these strange things that I tell him not to do, or he has no desire to get up and help me, or no, motivation to move. Believe me, these are all very, very common things that I hear. And I don't like to give people excuses, but again, you do have a pretty good excuse, right? With brain changes, you get some of these problems. With dopamine loss, dopamine is the reward pathway. It's a reward chemical. And so you're not going to get the same reward for doing activities. That really takes away a lot of motivation. And so you do have a lot of outs or excuses here to say, well, people with Parkinson's disease have a lot of changes in their brain. It's probably the disease. But then again, a lot of people who live in Pittsburgh are pretty stubborn too. And so I can't necessarily say that that's not the case. At the end, myself included, I'm not discluding myself. Just ask my wife, I'm a very stubborn person. At the end of the day, it doesn't really matter what's causing it though. And so it is something when we're talking about making judgments or making decisions or poor judgment or things of that nature, we still have to talk about it. We still have to think about it. We still have to potentially address it if we can. And it doesn't really matter if this is a personality thing or this is a brain thing or if it's a combination of both. The end result is if it's disrupting life, then we have to figure out a way around it. Is this cognitive therapy? Is this a medicine? Is this, is it, getting somebody to the caregiver support group to try to work through this? I mean, there's several ways we can work on this, and realistically, the underlying cause is much less important than actually taking it on and trying to figure out what to do about it. What is the best way to combat drooling? Best is subjective. That's a tough one. I mean, I have an opinion, and I'll tell you in a second. Botox or other injections, what injections are best? How long do they work? Drops on the tongue, are they covered by men? There's a lot of questions here. So drooling is very common. So people with Parkinson's disease tend to sit with their mouth hanging open. They tend to have extra secretions. They tend to be flexed forward, and gravity works, so everything comes out. And it's very frustrating. It's very embarrassing for a lot of people. It keeps them from going out. It really does bother a lot of people. And there's a couple different ways you can try to tackle this problem. There's pills. So we'll use Robenol or glycopyrrolate, which tends to dry things up. Sometimes we'll use like amitriptyline or something like that, but they have a lot of side effects. You could argue that a scopolamine patch sometimes is a little bit drying, or atropine drops are the drops they're talking about. They go into the tongue. They can also dry things up. Atropine is a little bit tougher to get. I've had better success getting that in more like the hospice settings than just typical day-to-day life, but it's not impossible. I've seen it done. But my favorite choice is actually the injections. That's what I personally, this is my own opinion, have had the best success with. And actually, there's 3 different injections that are approved. So Botox is approved, Xeomin is approved, MyoBlock is approved. These are all botulinum toxins. Botox is actually a brand name. Most people don't know that, but there's actually 4 different commercially available botulinum toxins. I don't think Dysport's approved for this. My favorite is actually MyoBlock. So MyoBlock is a botulinum toxin that I think is more drying than Botox or Xeomin. Now, that's not proven. There are no head-to-head studies. This is not in the literature. This is just my opinion. And so my first choice for drooling is MyoBlock. I have had success with Botox. I have had success with Xeomin. I've had success with the pills. And so it is, again, much like everything else that we do a lot of trial and error. But if you ask my opinion, that's the best medicine to try to work on sialorrhea or drooling. They are generally covered by Medicare or insurance, as far as I know, although I'm not the insurance expert by any means. Although all of them also have some sort of out-of-pocket copay expense, so on and so forth. So it's definitely something that has to be looked into before you just jump into it. And when you're talking about injections, you also have to think that I'm going to come at your face with a needle a bunch of times. So if that's not something you're keen on, then maybe that's not the best choice. These are all the things that we use to help make that decision. But in my opinion, MyoBlock is the best choice. That's what I've had the best success with. Yeah, this is such a tough question. And we talked about this, but this is a good question for everybody, because at some point in time, everybody's going to run into this problem. We're going on a trip out west where there'll be a 3-hour time difference. How should we adjust the medication schedule? I don't know. That is the God's honest truth. I don't know. I've had people do everything. I've had people try to do it preemptively because again, when you're going to California, it's 3 hours, something like that. 3 hours behind us. You're going to Europe, you get another time change. Again, and my patients like to travel. Most of them are retired or heading into retirement. They like to go places. And so I've had people do all kinds of things. And I don't know that anybody's ever come back and said, wow, this worked great. I've had patients who were going for longer and they try to get acclimated before they go. If you're just going for a week, is that enough time to actually acclimate to the time change and adjust your pills accordingly? I don't know. Everything is trial and error. I don't know that anybody has ever said, hey, this is what I did and it works great. If you did something that worked great, let me know, because I do get this question not infrequently and I don't know the answer. It also depends on what you're taking and how frequently you're taking it and how you're taking it and what time you get up and what time you go to bed and what time meal. I mean, there's so many variables for this. It makes it infinitely challenging to figure out a good answer. But if anybody ever comes up with a good answer, I would be more than happy if you would share it with me, because this is not the only person who's ever asked this question. What people usually do, in my experience, is they kind of wing it, right? You get there. You figure out how the schedule affects you. It usually takes a day or two. You figure out that you eventually end up on the schedule of wherever you go, and then vice versa. You have to figure it out when you come back. It usually is a day or two process in the patients that have told me when they've tried doing this, just to feel like you're getting back to your normal self. Does that affect how long you want to go on a vacation? Maybe. Things to think about. It's not just kind of jet lag or flight lag that you get. There is something to do with the medicines and changing the times too. So I don't necessarily know the right answer to that question, but it is something worth thinking about for people who are doing traveling. And if anybody figures out the right answer, let me know. Sorry, the next question is long and I read slow. All right. My husband is due for a colonoscopy every 3 years due to having polyps. This will be his first since Parkinson's diagnosis. He's falling as many as 3 times per day, so the prep is concerning, plus the potential impact of anesthesia. He's 72. Curious what you would recommend to a patient in this situation or what factors outweigh others in deciding. I don't know. That seems really subjective. And I'm a brain doctor. So of course I'm going to lean towards the brain and the movement disorder being the most problematic. I am not a colon doctor or a GI doctor, but these are all really important things to think about, right? I mean, so I'm not entirely sure what the risk of having polyps and having it convert into cancer is. I assume that's why they do colonoscopies every 3 years, because colon cancer is a really big problem, very common, and probably there's some statistics or data to suggest how frequently or how concerning it is for a polyp to convert or change or become cancerous. I don't know any of that data. I am by no means the expert on that one. And so this would be a really good conversation for the GI doctor. How concerned are they, right? Are they just doing it because this is standard practice? Or are they actually thinking about them and saying, nope, this is needed because I see these polyps and there's this percentage chance that this could become cancerous. And the earlier we find it, the better the success is. Those are two very different things. I'm not a huge fan of people doing things just because this is standard protocol, especially in situations like this. But if they have a good reason or a compelling reason, then yeah, you should probably get it. If he's falling 3 times a day, that's a problem. That needs to be worked on anyway, because falls are the most dangerous problem. This needs to be worked on, either medicine or physical therapy or a cane or a walker or something needs to be done here. So again, if you're my patient, we need to be working on this in terms of what do we do to try to work on that falling risk, regardless of the prep or not. Obviously, the bowel prep for colonoscopies is not the most fun thing. I've never done it, thankfully, yet, but not the most fun thing in the world from what I understand. And so it does require a lot of moving to and from the bathroom from what I understand. And so mobility needs to be working. But it sounds like we need to work on walking and balance to begin with. And then the other part is the anesthesia. So it's not unknown, or it's fairly well known, that anesthesia is not great for the brain. And so you take somebody who already has a brain problem, and now you're going to put to sleep their brain, even if they use twilight, which they usually do, I think, for colonoscopies. It's still not great. It's much better than general anesthesia, but it's still not great for the brain to be artificially, put to sleep or sedated. And so you're gonna run the risk, no matter what kind of procedure you have, what kind of surgery you have with anesthesia, flaring up symptoms, progressing symptoms, making things a little bit worse. Again, this is where you're weighing out risks and benefits, right? Everything we do is weighing out risks and benefits. Everything has a risk. There's no such thing as a free magic, and everything has a benefit. Otherwise, we wouldn't be doing it. The key is trying to maximize the benefits and minimize the risks. And you definitely at least have to pick a choice that the potential benefits are more than the potential risks. Otherwise, it's not a very good choice. So if you take somebody who's high risk of colon cancer, and if you find it early that you can actually cure it or fix it, that's a whole lot of benefit to doing a colonoscopy. And then the risks are outweighed for that patient. But if you have somebody who's falling all the time, who's already kind of going, we don't really want to do a lot of anesthesia because that can make things worse. There's not really a great reason to do a colonoscopy. Then you have to rethink. But you can imagine how those are two very, very different scenarios. And this is where the thought process has to come into play. Again, this is what I tell all of my patients when they call me up and say, hey, I have to have a knee surgery, or hey, I have to have a hip surgery, or hey, I have to have a back surgery. I say, well, do you need it? Usually the answer is yes. Nowadays, surgeons are pretty good about not operating on people who don't need it. And if you need it, you need it, right? Yes, I may have to do more work afterwards, But what I usually tell my patients is they're not just going to give you a shot of whiskey and a stick to bite on anymore. They're going to knock you out. And so we just have to work around it because the benefits of doing the surgery are that great that we have to accept the risks of anesthesia. That's exactly how I would approach that type of a problem. It definitely requires discussion, both with your neurologist or your movement disorder specialist, but also with your GI specialist. And no, do not expect those two people to talk because doctors don't ever talk. Not going to happen. They'll tell you they're going to talk, but they're not going to talk. Doctors are terrible when it comes to stuff like that. Communication's poor. And so you really have to ask those questions yourself to make a good decision. But that's how I would tackle that problem. That's what I would think about. So the follow-up question is, do anesthetics affect Parkinson's? And the short answer is yes. So I did a poster which is hanging in Allegheny General here from a whole bunch of years ago. No, that's a different poster. I did a study when I was a fellow, which is now really getting up there in years. I'm not even going to tell you how many years ago that was nowadays. Let's just say it was a bunch of years ago where I looked at this. I tried to compare people who had general anesthesia to people who had spinal anesthesia or lesser types of anesthetics and how it impacted Parkinson's disease, mainly in terms of how they did from a evaluation standpoint and how much medicine they took. And when I looked at this, what I found was people who had general anesthesia did often need more medicine afterwards. Interestingly enough, people who had any type of anesthetic, even spinal anesthetic, local anesthetic, also tended to need a little bit more medicine statistically, but it was much less than the people who got general anesthetic. And so my extrapolation from that, or my conclusion from that, was any type of artificial sedation or anesthetic is not good for the brain, especially in people who are vulnerable, who already have a brain problem. However, again, you have to take that with a grain of salt. If you need a surgery, if you have a problem that is impacting your day-to-day life or your quality of life, and surgery is the best way to fix that, then you need to have surgery. I have these conversations with a lot of people all the time in terms of knees. Knees are always the most common one, sometimes hips, but mainly knees. If you're not walking and you're not exercising and you're not doing all the things that I'm yelling at you about, because those are my favorite things to talk about, because of your knee needs to be fixed, plain and simple. Yes, there's a risk, but there is such a greater risk to not being active. Same thing is true for hips and backs and shoulders. At the end of the day, if it takes a surgery to get you more active and moving or preventing colon cancer or whatever, it's worth the risk. We just have to figure out, what to do about it afterwards. And so what I usually say is I'll pick up the pieces afterwards. I can adjust medicines. We can do therapy. We can figure out ways to try to get you doing better if that's what it takes to get you through the surgery and get this done so that you can do better for yourself. That's generally my thoughts on surgery, on anesthesia. There is an impact there, but sometimes it's necessary and we just have to figure out ways around it. And that's probably true for colonoscopies or eye surgeries or, whatever else they do sedation for in terms of people. It's always weighing out the risks and benefits. I actually ended early, but again, that 3 minutes early. When has that ever happened? So with that, I'll stop and I'll send it back to you, Casey.
Yeah.
As she did mention, I do want to reiterate. So I have another meeting on December 7th that I can't miss. And so that's why I can't do this next month. So we'll just do it again in January. So save all your questions for January. I'll answer them then. We'll talk on the new year, go from there.
Okay, thank you, everybody. Hope to see you next week on the webinar or another program soon. And don't forget to check out the caregiver retreat. Bye, and thank you, Dr. Leichliter, as well. Bye.
Thanks, guys. Have a good one.